Hi, everyone. Welcome back. Thanks so much for tuning in today. I want to talk about the most common arrhythmia, atrial fibrillation. So as we have mentioned in prior videos, an arrhythmia is an abnormal heart rhythm, and atrial fibrillation is the most common arrhythmia. So our topic today, of course, is atrial fibrillation. We will talk about this arrhythmia, which originates at the top part of the heart, and we'll talk about the symptoms it can cause, we'll talk about the consequences involved, and we'll talk about the different treatments. We'll talk about who's at risk for this, we'll talk about the treatment options, we'll mention ablation, but that will be discussed separately in a separate video, so look for that. So let's start with a little bit of background. The heart is a muscle. Any muscle in the body needs electricity to contract, so just like if you're squeezing your arm or your leg, electricity runs down a nerve, and that causes it to contract. In the heart, it has its own electrical system, which is automatic. And in that, the top right part of the heart generates electricity, and it goes from the top to the bottom part called the ventricles, and that causes the bottom part to beat. In normal rhythm or sinus rhythm, the sinus node, our native pacemaker, generates electricity. And the nice thing about it is appropriate to the situation. Our sinus node is innervated by our brain, and so if we're running, it'll pick up and go fast. If we're relaxing, it'll just pace at a normal rate, around 60 to 80 or so. With atrial fibrillation, however, this gets disrupted. So let's take a look at this drawing I made. The heart is a muscle, and it has 4 different chambers, 2 on the top, 2 on the bottom. The top chambers are called atrium, or atria, plural, and the bottom ones are called ventricle. They're separated from each other by valves, and they beat independently. They beat sequentially. There is a pacemaker of our heart called the sinus node, and that sends electricity from the top part and then down to the AV node, which then sends it down to the rest of the heart through the ventricles. So in normal heart rhythm, electricity comes from the sinus node, and it spreads like a wave across the atrium. It tells the top chambers to contract together. It then pauses at the AV node. It allows for blood to fill, and then it tells the bottom chambers to contract. And that process repeats over and over, and it's nice and rhythmic, and that's why our heart rate is typically nice and regular. In atrial fibrillation, however, what happens is that you have chaotic electrical activity all over the atrium. So instead of one wave, like in the ocean, spreading through the top of the atrium, you get this atrial fibrillation, or this fibrillation fluttering all over the top part of the heart. And that bombards the AV node, and that makes the heart rate fast and irregular. On top of that, if the heart is beating so fast, it's not beating well at all. It's beating in a disorganized fashion, and that, unfortunately, can cause a clot. When blood doesn't move, it can clot. And those are the clots that can cause the most dangerous consequence of atrial fibrillation, that of stroke. So the importance of managing atrial fibrillation is several. The first is to prevent stroke. The second is to control the heart rate, and the third is to control symptoms. We'll talk about each of those. With regards to stroke, when the top part of the heart is beating so quickly, it doesn't get a good kick of blood from the top to the bottom. So the top part's just quivering, and that can lead to blood clotting, and those clots can cause stroke. The way that we treat atrial fibrillation with regards to preventing stroke, is typically with blood thinners. So we use this old drug called warfarin and these newer medicines, Eliquis, Xarelto, and Pradaxa. For people who can't be on a blood thinner, there are certain devices that we can put into the heart that greatly reduce the risk of developing a stroke. The second major consequence of atrial fibrillation is the rapid heart rate. So normally our heart rate is controlled by our sinus node, and that gives a nice and regular heart rate, and it typically keeps the heart beating about 60 to 100 beats a minute. With atrial fibrillation, typically, because of the chaotic electrical activity, the heart rate is typically elevated. This gives some people symptoms such as palpitations where they feel their heart racing. But even if you're not having symptoms, if your heart is beating this quickly, it can start to wear out. The wearing out of the heart, or the weakening of the heart, is called heart failure. So at a minimum, we have to keep the heart rate less than 110 beats per minute. So we do this with medications to slow down the conduction from the top to the bottom. The other consequence of atrial fibrillation is symptoms. Some people don't feel anything at all and they're asymptomatic. And for those people, we can often just control the heart rate and prevent stroke. But other people feel it. Some people feel it discreetly. They feel it the minute they go out of rhythm. And then some people feel it gradually as time accumulates. So what I often offer is for anyone who's had fatigue or palpitations or shortness of breath or dizziness, we often recommend restoring normal rhythm, and we talk about strategies to keep people in normal rhythm. If someone isn't sure, I often recommend shocking the heart through what's called the Cardioversion, because then you can compare directly how you felt in atrial fibrillation to normal rhythm. One concept that is important to understand as you make your decision as far as how you want to treat your atrial fibrillation is the pattern of atrial fibrillation. Atrial fibrillation is a progressive disease. The more you have it, the more the atria, or the top part of the heart, remodels, and that leads to actually more atrial fibrillation. If you do nothing, what ends up happening with atrial fibrillation is initially it is paroxysmal, meaning occasional. So you'll go into atrial fibrillation, and then you'll go out. You go into atrial fibrillation, and then you'll go out. As time wears on, you tend to go into longer episodes that occur more frequently, and it reaches a certain point where it sticks. And at that point, you can't get out of it on your own. You need what's called the cardioversion. And even if you do nothing, even at that point, at a certain point, it becomes permanent, where we can't keep you out of rhythm at all. So that's the natural history of atrial fibrillation. It's important to kind of keep that in mind. I also want to take a moment to say that atrial fibrillation is a difficult disease, and if there's anything that can be modified, you ought to do so. So if we'll always check an echocardiogram to make sure your heart valves are okay, that your atrial fibrillation isn't coming from a problem of your heart valve. We'll check your thyroid, because an elevated thyroid particularly can lead to atrial fibrillation, and we'll recommend lifestyle modification. So if you're overweight, we recommend weight loss. Sleep apnea is very common, so we often recommend being tested for that, because that can certainly worsen atrial fibrillation. Excessive alcohol intake, especially excessive alcohol intake, can worsen atrial fibrillation, as can caffeine. So as far as the treatments for atrial fibrillation, there are three goals. We want to prevent stroke, we want to control the heart rate so we don't develop heart failure, and we want to restore normal rhythm, particularly if you're symptomatic. To prevent stroke, as we mentioned, we use blood thinners. To control the heart rate, we use medications like metoprolol, diltiazem, or digoxin. Rarely, we can use a pacemaker and what's called an AV node ablation. This is different than an atrial fibrillation, which we'll talk about later. And if people are symptomatic, despite good rate of control, we can offer rhythm control. Rhythm control typically involves a shock of the heart, a cardioversion, sometimes medications to keep someone into normal rhythm called antirhythmics, and ablation. Ablation is the highest chance of success for atrial fibrillation. It's a topic in and of itself, and we'll talk about it at the next video. So the first and most important goal is to prevent stroke and atrial fibrillation. The worst thing about atrial fibrillation, I'm afraid, is stroke. It can be devastating. So the way that we do that is by thinning the blood. So that makes it much less likely for it to form a clot in the top part of the heart and cause it. The blood thinners, as we mentioned, are warfarin, which we've used for decades. The hassle with that is it needs blood tests and it can interact with medication, and you have to watch your diet. These newer ones are much more forgiving. They don't need testing. Those are Eliquis or Xarelto or Pradaxa. The side effect for those typically is bleeding, so we have to manage someone's risk for stroke versus the risk for bleeding. And there's this newer category of devices called left atrial appendage occlusion. So for people who can't be on a blood thinner, that's an option that you and your doctor should talk about. And you should, anytime you're diagnosed with atrial fibrillation, and periodically, your risk for stroke should be assessed to target you for the best type of therapy. With regards to heart rate control, we tend to try to control the heart rate. For some people, that can lead to a reduction in symptoms. And for some people, they can eliminate symptoms. So we use medications to do that, using typically what's called metoprolol, a beta blocker, diltiazem, a calcium channel blocker, or digoxin, or some of the sisters or cousins of those medications within that class. And as I mentioned, rarely some people need a pacemaker for this. But for some people, that's not enough. For some people, despite thinning the blood, despite good control of the heart rate, they still don't feel good. And for those people, we recommend a rhythm control approach. And the way that we do that is by shocking the heart to get someone in normal rhythm and strategies to try to keep someone in normal rhythm. So we'll talk about those approaches. We'll talk about the cardioversion, we'll talk about antiarrhythmics, and we'll talk briefly about ablation, and we'll talk about it comprehensively in the next video. The cardioversion, we may recommend that. That's a effectively non-invasive procedure, but it does require what's called a TEE, or transesophageal echo, where they put a probe into the mouth, into the esophagus, and we make sure that there's no clot. Provided there's no clot, then we give a jolt of electricity to restore normal rhythm. And that can be useful for people who don't feel good in atrial fibrillation. And then if someone's just feeling fatigued and they're not sure, this can be very useful to compare how much better you might feel in sinus rhythm. The good news about cardioversion is it's really easy. It is highly successful. The bad news, though, is it's a lot easier to get someone in normal rhythm. It is more difficult to keep them in normal rhythm. Sometimes we use what's called antiarrhythmic medications. These are medicines that can help hold you in rhythm. They all have risks and side effects. Typically, the stronger medicines have higher risks and higher side effects. And some of them are not options for all people. So we have to do testing to make sure that these are safe in your particular heart, to make sure that they are safe for you. And some of them have to be initiated in the hospital. These are not medicines to be taken lightly, but they can help hold you in rhythm. Success rate's not great, though. Success rates are typically less than 60, even with our strongest medicines at 2 years of holding in rhythm. We'll talk about the most effective treatment, atrial fibrillation ablation, in the next video, but briefly, it's a procedure where we go in through the vein, we enter the heart, we modify where atrial fibrillation comes from. And for some people, it can eliminate their episodes, and other people, it can greatly reduce it. We'll talk about success rates and talk about that in a little bit more detail. It does not eliminate the need for blood thinners. And one thing that we'll mention in the next video, but it's something you should know, you will have a higher chance of success intervening early with atrial fibrillation ablation. So we'll talk about that a little bit more. Thank you so much for tuning in. This is the most common arrhythmia, so I know it affects a lot of people. Just wanted to give a brief overview. The care of atrial fibrillation needs to be individualized. So see your doctor, talk about it specifically in your case, and then you can form a plan here. But I hope this provides a little bit of background, and I'll see you next time.